Hey all, welcome back to the Real Life Pharmacology Podcast. I'm your host, pharmacist Eric Christensen. Thank you so much for listening today. We're going to be continuing on with the top 200 drugs. We are starting off at 106. Before we get into that, as a reminder, go check out meded101.com/store. We've got a ton of resources there, pharmacist board certification study materials. We've got things for nursing students. We've got things for pharmacy technicians. Again, tons of resources there to help you in your journey of learning medications, helping pass board exams. Again, go check out all those resources at meded101.com/store. Your support there goes directly to support the Real Life Pharmacology Podcast. All right, so drug number 106 is Zoledronic acid. Brand name of this medication is Zometa and reclassed. It is a bisphosphonate. So if you remember from previous medications, a bisphosphonate is basically a medication that can be utilized for osteoporosis. Zoledronic acid can also be used in the hypercalcemia of malignancy management as well. So that's an important indication to remember too. So again, as a reminder, bisphosphonates in general, they prevent bone resorption by inhibiting osteoclast. That's definitely a mechanism that I've seen come up on pharmacology exams and board exams throughout my career. So remembering that bisphosphonates inhibit osteoclasts is really, really important. This medication is an IV injection, typically given over 15 minutes. And it is dosed on an annual basis in the management of osteoporosis, typically. Adverse effect profile. So with this IV injection or infusion over 15 minutes, flu-like symptoms can happen. And they can last for, a period of days, maybe even up to a week or two. After that injection. Patients, it is okay typically, as long as there's no contraindications or anything, that we can utilize acetaminophen to kind of help manage this adverse effect if it's bothersome for patients. Other adverse effects that you may see pop up, potential for GI adverse effects. Obviously, this is probably less common or less of an issue than giving oral bisphosphonates, which can kind of cause that direct insult on the esophagus and on the GI tract there. Myalgia, muscle pain, muscle soreness can happen, particularly in the short term following administration of this medication. Other things to consider because of its mechanism and the way it works on bone resorption and the interplay with calcium. It can contribute to low calcium and cause that issue, which obviously makes sense if we're using it for oncology purposes to manage hypercalcemia. Obviously, we can bring that calcium level down too low as well, so that's something that should be monitored and paid attention to too. There are some associations with acute kidney injury with this medication. We do have a contraindication if patients have a creatinine clearance less than 35 mils per minute, maybe slightly lower when used for oncology purposes. But again, very, very important to pay attention to renal function with the use of this medication. And then kind of the last wacky thing, osteonecrosis of the jaw has been reported with bisphosphonates. It is very rare, but always a good idea to involve dentists when we know patients are using this medication. Drug interactions, probably the biggest thing I pay attention to are the acute kidney injury issue and the low calcium issue. So AKI risks, obviously I think of aminoglycosides. It's also recommended typically to avoid NSAIDs if possible. That may be tempting for some clinicians to use because we have those flu-like symptoms, and NSAIDs would likely help with that. But because of the risk of AKI, typically we would want to use acetaminophen and try to avoid NSAIDs if possible there. Low calcium levels, those could be exacerbated by loop diuretics like furosemide. So again, you may have an additive attention there to that. And then steroids, PPIs, I always think of medications that oppose what we're trying to do with the medication. So if we're using this medication to treat osteoporosis, remember some of those drugs that could worsen or cause osteoporosis. So again, corticosteroids and PPIs are a couple of common ones associated with osteoporosis. Medication 107 is Glipizide. Brand name of this medication is Glucotrol. It is an anti-diabetic medication classified as a sulfonylurea. I would say the most important thing you can recognize here is identifying that glipizide and sulfonylureas in general stimulate beta cells in the pancreas to release insulin. And whenever we release insulin or add insulin from an exogenous standpoint, we give insulin, that can increase the risk for hypoglycemia, and weight gain can also go along with that as well. So definitely have to pay attention to hypoglycemia risk when you've got a patient on glipizide. And it's really, that in combination with the weight gain issue, really why it's fallen out of favor as far as a preferred type 2 diabetes agent, is because of those two reasons. On the positive side with this medication, it is very affordable. It's cheap. It's oral, so that can certainly be, an advantage in its corner. But again, those adverse effects generally are limiting its use more and more compared to some of the newer diabetic agents like SGLT2 inhibitors and GLP-1s, for example. So paying attention to eating, diet. So if patients are erratic with their meals, they skip meals, that type of thing, glipizide may be a challenging medication to utilize here because if we're trying to stimulate that pancreas to produce insulin and now all of a sudden you get a patient not eating, that hypoglycemia risk probably goes up a little bit there. There is some caution with sulfa allergies. The chemical composition of this medication, we do have a sulfa component, so some caution should at least be used there. And may be contraindicated, depending upon past reactions and what we've seen with other medications with sulfa components in it. So definitely something to at least have on your radar there if you've got a patient with severe allergic reaction risk due to sulfa drugs or similar type medications. Drug interaction standpoint, certainly I always think about other diabetes medications being added on top of this that lower blood sugar, using a sulfonylurea in combination, we can exacerbate that hypoglycemia risk. A couple others with this medication specifically, CYP2C9 inhibitors may increase concentrations. Not something I crazy worry about, but something I think that should be monitored. And then beta blockers, they can blunt some of the signs of hypoglycemia and may make it a little bit more likely that patients experience a severe episode. So a few drug interactions there. Moving on, we've got number 108, that is Lactulose. This is classified as a laxative. However, we've got a lot of other laxatives that are typically preferred. So where I see this medication used is hepatic encephalopathy, more so than constipation. Basically, bacteria in the gut break down lactulose into lactic acid, which increases kind of pH in the GI tract. And this ultimately turns ammonia, which is found in toxic levels in hepatic encephalopathy, into ammonium, which is not as easily absorbed back into the body, and so it basically stays in the gut. We also get the osmotic gradient so that draws water in, which is why it's potentially helpful as a laxative, as well as decreasing ammonia levels in hepatic encephalopathy. Adverse effect profile, obviously it's probably in line with a lot of other laxative type agents, diarrhea, abdominal cramps, those type of things. With the dosing in hepatic encephalopathy, lactulose is typically titrated to 2 to 3 bowel movements per day. This can be a challenge for patients and ultimately lead to some adherence challenges if stools get too loose or too frequent. So that's just something to monitor in patients with hepatic encephalopathy. Using it to reduce ammonia levels is just touching base with them, seeing how that's going, and then obviously we can monitor those levels of ammonia as well. From a drug interaction standpoint, typically not too much to worry about here, in my opinion. Rarely may increase INR in patients taking warfarin, and then obviously if we have too many bowel movements, loose stools, you can obviously run the risk of dehydration, as well as reducing some of those electrolytes, hypocalcemia typically being the most common there, and that can certainly be exacerbated if we've got patients on, let's say, loop and thiazide diuretics. Number 109 is Rabeprazole. Brand name is Esophagus. This is a proton pump inhibitor. It inhibits or prevents gastric acid secretion by inhibiting the hydrogen-potassium pump on parietal cells within the gut. Indications: GERD, peptic ulcer disease, gastric ulcer, things like that. Adverse effect profile: usually PPIs in general are pretty well tolerated. Maybe some GI abdominal pain reported, maybe headache, again, low percentages in general. But the long-term adverse effect profile is significant, and there are definitely some associations and risks with long-term PPI use. So again, unless we've got certain conditions that warrant long-term use, Barrett's esophagus, for example, we really want to try to minimize use if possible. So, generally for GERD, we're targeting, that 4 to 8 week range for management there, and then ultimately trying to reduce and get patients off these medications if at all possible. And some of those long-term risks are low B12 levels, osteoporosis has been reported, C. diff risk, low magnesium is another one. So again, some pretty problematic risks. Again, not crazy high associations, but again, just goes to the point of trying to reduce medications, trying to get rid of medications whenever possible, so we don't increase those risks. Typically, PPIs like Rabeprazole here should be taken with the first meal of the day. From a drug interaction standpoint, the biggest thing I typically worry about is absorption of other drugs that maybe need an acidic environment. Probably two of the most common I see with issues, so iron absorption can be reduced. So patients taking iron for anemia purposes, for example. One antibiotic that probably comes up most frequently is cefuroxime. So again, it can block or reduce the absorption of that cephalosporin antibiotic. Interestingly, it may, because of the alterations in pH, there are some medications that have more absorption under that situation. So it may increase amphetamine derivatives, for example, as far as absorption goes. Methotrexate is another one that can have absorption increased with this medication. And then alternatively, thinking about the adverse effect profile, we can potentially oppose bisphosphonate action in managing osteoporosis. So a few drug interactions to think about there for sure. And finishing off, we've got medication 110, and that is Methotrexate. The class of this medication is a DMARD, which stands for disease-modifying anti-rheumatic drug. Mechanistically and indication-wise, it can be used for oncology purposes, various types of cancers. It also can be used for autoimmune diseases or disorders. Ultimately, from a mechanism standpoint, it prevents DNA synthesis, repair, and cellular replication by acting as a folate antimetabolite. That's probably the most important thing to remember if you're taking pharmacology classes or board exams. From a mechanism standpoint, it's a folate antimetabolite. So binding to and inhibiting dihydrofolate reductase. The exact mechanism in rheumatoid arthritis is a little bit more blurry, but the immunosuppressive nature of the medication is likely what's playing a role in reducing, rheumatoid arthritis flares, for example, there. Adverse effect profile. GI can certainly happen, nausea, vomiting, diarrhea, particularly at higher dosages, especially with oncology type dosages, which are much, much higher than the dosages used in rheumatoid arthritis or ulcerative colitis, for example. So that's definitely important to remember. You can have some central nervous system things as well, fatigue, stuff like that. And then the other important one that I've seen tested on quite a bit are increased liver enzymes. So those elevations in LFTs are something to definitely pay attention to as well. We've got a few different dosage forms. We've got injectable dosage forms as well as oral. Oral is what you're most commonly going to see in the management of rheumatoid arthritis, typically given once a week. Some considerations avoided in pregnancy, typically there, hazardous type medication, and supplementation with folic acid. Again, classic board exam, pharmacology exam question there. So we need to supplement folic acid to help reduce some of the adverse effects with this medication. Avoid taking methotrexate with alcohol. That's that hepatotoxicity risk that comes into play there. As far as drug interactions, medication-wise, so alcohol, obviously I mentioned there. There are agents that can kind of have additive effects where we suppress the immune system, for example. So, cyclosporin, for example. PPIs can actually increase concentrations of methotrexate. Live vaccines are another thing that should be paid attention to. The effectiveness of live vaccines can actually be reduced. So that's an important thing to remember there. Bactrim can increase concentrations of methotrexate. So I'm probably not crazy worried about it in, a 3-day, 5-day course of Bactrim. It's probably more concerning in patients who may be taking Bactrim for UTI prophylaxis, for example, where they're on it for a long time. So again, another important drug interaction to kind of pay attention to there. All right, well, I think that wraps up the podcast for today. Do me a huge favor, share us with friends, colleagues, students, those that can benefit from pharmacology education. We're definitely looking to help educate as many people as we possibly can. Hopefully this podcast has been useful to you, and we certainly hope you share it with others as well. You can also leave a rating review on iTunes or whatever platform you're listening on. I greatly appreciate that. I appreciate the support, the kind words. It helps definitely keep me going and helps me share the things that I've learned over the years in my practice as a pharmacist. If you want to reach out to me, comments, suggestions, mededucation101@gmail.com. Also, be sure to support the sponsor, meded101.com/store. We greatly appreciate that as well. With that, I'm going to sign off for today. Thank you so much for listening, and I hope you have a great rest of your day.